I tell patients all the time, surgery is the failure of medicine. Not to say that we medically treat endo and when that fails, we excise, but to emphasize the importance that surgery has its limits. There's so much surgery can do for you. The rest of it is not surgical. It's not invasive. It's partly medical, but a lot of it is not medical.
Well, this is going to be an amazing conversation. I've got Dr. Rayan Elkhattah here with me today, who is an endometriosis surgeon who's recently relocated here to Los Angeles to help us in the baby making field. But he is not new to this field, and he's got a very unique approach to working with his endometriosis patients. And that's why you're here today. I really wanted to talk to you because I feel like there's a lot of overlap between the way that we work with our patients. And I know there's a lot of conversation going about endo right now, and my patients might think, oh, another endometriosis conversation. But I promise listeners, this one is different. Welcome to the show. Thank you so much for making time to join me today.
Thank you so much for having me. It's a pleasure to be here and advocate for what we do, what you do for the patients, and having them think outside the box of standard biomedical practice.
Right.
Yeah.
Right. Which is an interesting thing to say as you are a surgeon, right? Not just like general medicine. You are actually going in, removing the endo. And I think what we're going to talk about is poetic or woo-woo as we want to get is what is in there? What do you think it is you're cutting out? And how can we best support our patients from the East and the West, right?
Absolutely, yeah. It's not clear cut. I think the best way to sum it for patients is that endo is not just a disease that heals and goes away surgically. There's so much more that comes to healing someone with endo that goes beyond what we classically do as excision in our world. And we're going to dive deeper into that with this discussion right now.
Mm-hmm. And it's an interesting pun you used. It's not clear cut as you're an excision surgeon, right? Endometriosis excision surgeon, but it is pervasive endometriosis. And now we're hearing this term central sensitization. We're talking about all of the upregulation of the central nervous system. So we're going to be talking about that.
Yeah, and much detail and linking central sensitization to every person's individual experience of pain, inflammation, their own sense of their body image, how it somaticizes in their body, the somatification of central pain and its impact on their function. It's such a dense, complex topic, but we'll try to make it simpler for people to understand it.
Mm-hmm. And for you to say that it's dense and complex is validating for the listeners who, as I wanted to start with this term medical gaslighting, but these women are really struggling, whether it's pain or childlessness or recurrent pregnancy loss or postpartum after having kids, even in my case, having endometriosis affecting me in my menopause window. It is something that is very pervasive, and yet we can't seem to get doctors to admit that there's a situation brewing.
Yeah. I'd like to throw a notion here for people who are listening. I'm personally allergic to medical gaslighting. I have to throw it out there because you need to find someone who's allergic to medical gaslighting, who's ready to listen. That's the big thing with chronic pain, endo, any other chronic disease. You need to be able to listen as a provider. Medical gaslighting alone is simply just the effect and trauma that you receive as a patient when the provider who's trying to provide you with healing is not acknowledging your suffering, is not taking it into account in terms of your experience of the suffering pathway that you've been through, whether it's endo or anything else. It's so core in healing that we're not where we need to be as medical professionals in that aspect. And things are changing, but there's so much more work to do on that aspect. So to segue into medical gaslighting, it's been present for centuries. This is not something new. We hear more of it now because of social media and patients' experiences, but it's been with us ever since modern medicine started. Some buzzwords for you guys. Hysteria. The word hysteria. I mean, I know this is becoming more of a commonly used term to describe medical gaslighting historically, but technically, women in the 18th, 19th century who were having very severe, painful cycles, along with the chronic pain that comes with it, the term hysteria was pinned on them to refer to pain and psychological distress that comes at the time of a menstrual cycle. Mm-hmm. And attributing that whole experience to the uterus itself, really reducing this whole person's suffering into one organ and labeling it as that's the cause. Unfortunately, that's been happening for centuries, well before modern medicine came into the picture. After the 18th, 19th century, getting into the 20th century, this was more evident lately in the HIV, AIDS.
The era, like the 1980s?
Yep.
How so?
In terms of attributing it to the LGBTQ community, as opposed to this is a very clear viral infection with the following pathway, and destigmatizing all of it and not just attributing it to poor sexual behaviors as it was back then. And
do you mean a little bit of discrimination?
Absolutely.
Okay.
Yeah, if you look historically, most of the populations who were affected by gaslighting, medical gaslighting, women and gay men, people of color. Blacks, Native Indians, all of these populations were systematically medically gaslit, either by choice or either by lack of knowledge and understanding of disease process. So we're reversing that trend. We're working really hard to make it not commonplace, but it's so pervasive that we're just scratching the surface of how pervasive it is in modern day medicine, with aids of big institutes doing research on marginalized people and their health, with the discrepancies of care and inequities of care in all these populations. It's still present today. If you do just a simple cross-section, for example, of Black race and health outcomes across all disease processes, I know much of the GYN aspect of it, but it's everywhere. They're more prone to complications, poor care, poor follow-up, all the above. So there should be no room for medical gaslighting in modern day care, because it does matter in helping people heal.
What matters is the relationship that you have with your physician.
100%.
And to have this sense that they believe in your ability to have a successful outcome.
Yeah.
And some of this gaslighting, I think, results from a lack of time that they have to set aside for each patient case, potentially because we're all so busy in this particular field, or poor time management, or it's set up to not allow enough time. I don't know, but I think a lot of gaslighting arises, in addition to the reasons you just mentioned, they simply don't have the answers or a reason to explain what's going on to the patient. And so instead of saying that, it's inferred that it's something in the patient that's not right.
Yeah.
And especially when we're talking about women and fertility cases and endometriosis, again, women, we're so used to blaming ourselves, or it's something, or comparing to an ideal woman. So then there's this inner sense of, well, of course, it's something that I'm ate.
Broken.
Yeah, it's something that I did. It's something that I was brought up with, or something that happened to me when I was a kid. And they would just like take that, or this, well, I must just be crazy, you know?
Yeah.
That is, so I think like this is great for you to mention where it comes from, but can you say from the MD perspective, what it looks like so we can really validate the listeners, because as we know, endometriosis takes about 10 years before it can reach the surgery point on the journey.
I want to mention a statement that I heard in a recent endometriosis summit. The eye cannot see what the mind cannot imagine. So step one on the MD physician side of assessment, it simply takes one step of humility to sit down and just listen to the patient. Just listen. If you can dedicate 15 minutes of your appointment to listening, you've done half the work. In our practice, we hear a lot of patients saying, my body's broken.
Yeah.
I cannot figure it out. I've seen so many people to get care and nothing's improving. Why is my body doing this? What did I do to put myself in this situation? And to some extent, patients also stop listening to their bodies, and that accentuates this whole process of self-blame. And it propagates this whole notion of, I'm never going to get better.
Right.
Hopelessness.
Right.
Learned hopelessness. And then our job as physicians is to identify that, deconstruct it, provide the patients a safe environment where they can genuinely feel heard. The healing is partly surgical on the endo part, on endo world, but a lot of the healing is not manual. It's not physical. It's simply acknowledging that this patient is suffering. And the moment you do that and they know that you're hearing and listening to them, it opens up, everything opens up. When that happens, you can then deconstruct what's contributing to pain and set them on a pathway to recovery.
In Chinese medicine, we refer to this as like a root and a branch treatment. So what I'm hearing you say is when we acknowledge their pain and suffering, that's speaking to the root of some of what's going on. Branch, by the time we're working on the branch, it's giving them pain medications or surgery or suppressing them with hormones.
Yeah.
And that's not addressing the root, which is part of why we have, I'm going to put this under medical gaslighting as an umbrella. The quick comment is, well, why would we want to operate when it's just going to come back?
That's so true.
And as a patient whose fear is that it's never going to go away, to hear that surgery can't take it away either, is devastating.
It is, especially for those who've had surgery and they haven't noticed or realized the benefit they were hoping for. That's a hard one.
And I've had 3 laparoscopies. The listeners that have heard other episodes know this about me, but I just want to throw in, the first surgery was from a surgeon who was a new resident. And so he said, I see, when I went inside, I just saw a bunch of fascia. It was clear and opaque. It wasn't characteristic of endo. There was a freckle size, and that's what I removed. And I had no relief from the pain, but excision surgery number 2 and 3, they were 17 years apart. And both times what I went in with, I didn't have coming out. And that first surgery allowed me to have 2 kids conceived naturally with 1 attempt only at advanced age with a low egg reserve. So something changed, and it wasn't just my mindset. And in the later one, similarly, the pain that I was having radiating from my sacrum down to my legs was remedied, as he was able with the technology to use a robot arm to move my uterus out of the way and to clear the sacrum. So to tell patients that it's just going to come back, that I think is erroneous too. And that's where patient care, patient education, telling them how to avoid some of the inflammation, telling them how to do pelvic PT, and informing them and helping them to find a surgeon that's going to excise the
It's
lesions.
a 3-prong approach. Prong number 1, multimodal therapy. Prong number 2, physician skill in properly identifying and removing / debulking the disease. Yes, it recurs, but in expert hands, the recurrences are very, very low. And the third prong is the patient. We can't do what we need to do for the patient without them buying into the multimodal approach and downregulating. We can't do this without them. And I tell patients all the time, surgery is the failure of medicine.
Can you?
Okay, this is a big, very heavy statement, and I stand by it. Not to say that we medically treat endo, and when that fails, we excise, but to emphasize the importance that surgery has its limits. And yes, it's important, it's vital in removing inflammatory disease, which endo is, reestablishing anatomy, freeing the organs, all that stuff. That's so important. But more importantly is the fact that people understand that, yeah, I saw an endo excision specialist, I didn't feel better. There's so much surgery can do for you. The rest of it is not surgical. It's not invasive. It's partly medical, but a lot of it is not medical.
It's more like self-care.
Correct.
Or learning how to live.
Yes. So healing in the world of endo is a way to redefine your trauma so that you're not in it all the time. But when you do the multimodal self-care with guidance in a setting where there's a multidisciplinary approach, like I cannot, as a surgeon, give a patient the optimal result of getting their quality of life back without a team of people who understand this disease from a perspective that's not gynecologic. And that spans the whole breadth of functional medicine, integrative medicine, physical therapy, acupuncture, dietary changes,
mind-body, self-regulating,
cognitive behavioral therapy, vagal down regulation, up regulation, I guess, for the vagus. But the point is, I can only do so much surgically, and then the rest of it has to be that other approach of multidisciplinary and patient involvement in their own healing. Because zero pain, we never guarantee that. But what we guarantee them is you will get better if you follow this pathway, and your pathway to heal, you have to define healing in terms of function as opposed to no pain. That's where most physicians today are not trained, nor have the genuine belief that that works. And that's what the changes are all about. Like, I'm one person, and every single surgery counts for reduction of this collective healing and pain that patients go through. But there's some signs that things are changing. Patient advocacy groups are ballooning everywhere. Social media is a huge aid. It's a double-edged sword, but there's so much awareness out there. Medical school curricula are starting to incorporate trauma-based care, which is medical, social, emotional, sexual, all of that. And in our residency, so I was a residency program director before I moved out to this private practice situation. And in the 4 years of me as a resident program director, we finally were able to bring one person who specializes in trauma-based care to come and educate the residents about, what does this mean? Like, is it enough to simply be patient-centered? Or should we also incorporate the trauma that they've had into their healing pathway? Because when you do that, that's when true healing happens.
It really is about integrating what's happened, whether it's a frustrating situation in their marriage. To have this thing, I'm thinking of a particular couple of women patients right now, but trauma is on a spectrum, and you can be traumatized just with a scary situation, a long-standing situation, inherited from your bloodline, ancestry. It's what the body is perceiving. It's a sudden change in your living situation, various different sources of trauma, but this
The pathways converge.
Mm-hmm.
They all do.
Yeah.
I wanted to just, excuse the interruption, but this notion of how does trauma cause pain, whether it's sexual, emotional, social, medical, whatever you want to call it, how does it cause pain? And so the mind-body connection of trauma is well known. It's not new. Like, it's published. It's intense research about it, and these pathways converge, so to speak, in a way that if you have a history of trauma, you are on an upregulated pathway of stress, inflammation, and pain.
Mm-hmm.
And any trigger in the body that causes these can accentuate the scenario in your experience. And so it's so unwise to uncouple trauma from your role as a healer with patients. It's like you're shooting yourself in the foot.
Mm-hmm.
as a
And
provider.
healer extends to surgeons, the term healer.
Yes.
It's not just the woo-woo people out there like myself. It is physicians, surgeons as well.
Yeah.
And I'm glad to hear you mention this idea of just the act of being upregulated. And that can be from, as I was trying to say, and I think I kind of lost what I was saying, but like having rent to pay can become upregulating, or an argument can feel very uncomfortable. It doesn't have to be that there's physical abuse involved.
Correct.
And that sense of it's not safe at my home, you know?
Yeah.
And then it can also be in the context of central sensitization. I think we should probably talk about it here because it's a buzzword. I've got a patient. They're arguing at home. She's about a month into healing post laparoscopy. So she has 2 small kids and received a diagnosis of endometriosis. And after the surgery now, she suddenly has a bunch of angry nerves. So I hope some of the listeners are hearing that story and thinking, well, it's because the root of the problem hasn't been addressed. The problem is like between the couple is underlying, and communication and maybe counseling and some new skills to address that so that she's not being upregulated on the regular.
Yeah.
Is going to help, because when she came home from surgery and doesn't feel supported with the toddlers or with, hey, I need this or that, can you help me with it? Then feeling like he's not willing or able to be supportive, then it's triggering those nerves to be angry, and nerve pain feels burning typically. And burning is heat, is emotional heat, and Chinese medicine is anger. So it's the body telling us what is going on, like you said.
So for those who don't quite understand central sensitization, let's do a quick primer on that. So you sense pain through receptors in your body everywhere that all converge into pathways of nerve bundles that end up in the spinal cord and your brain. So if I poke you for years every day with a sharp object in a specific area, that pathway becomes upregulated to feel pain. So much so to the point that if I touch you with a non-sharp object, you will feel it as sharp pain. So I'm simplifying this, but what happens in chronic pain in the pelvis, for example, is all these nerves become upregulated, and the modulation of these pathways occurs in the spinal cord. It doesn't have to go up to the brain anymore. It becomes its own overregulated node of nerve tissue in the spine that does its own nerve modulation of these signals. So once you get to the point of central sensitization, it's hard to reverse it, because this nerve has become, that's its new nature, firing pain. So it's not, in the analogy of root and branch, the root is nerve endings that are upregulated, and the branch is I excised endo.
Unexcised?
I excised endo.
Oh, it's from having the surgery?
Correct. So the analogy here is it's not enough to just cut the disease out. Even if you're taking out the disease properly, there's nerves that are still working. So when you're healing post-op, most patients who have central sensitized pain worsen, and there's no guarantee they're going to get back to baseline. They do. With a lot of work, it takes around a year plus for central sensitization to start to reverse. And you can't just sit down and wait for it. You have to be proactive about the downregulation. So just like the nerves upregulated, they're plastic, we can reverse the upregulation by methodologies that reduce the pain by neuroplasticity. Luckily, our wiring can rewire. So just like it rewired to be painful, can we rewire it to be less painful / not painful? And the answer is yes. And once physicians believe that that's possible and empathize and acknowledge with the patient that this is what's happening, half of the battle is won. When you empathize and believe and you're humble about it as a provider, patients see it and they're more likely to adhere with the plan that you're putting out there, because you're not simply putting it on the side. You're not telling them it's in your head. You're not saying, I can't do anything for you. There's so much you can do. If you can't do it yourself, tell them where to go to get help. It's not about, like, us doctors, we fail to put our egos on the door when we walk into a patient room. We walk in with so much bias, so much, if it's XYZ, that's a diagnosis. Sure, you should know your medicine and be knowledgeable, but you cannot heal people if you can't get to their level and listen to them. Went on a little offshoot there. Back to central sensitization.
It's good though, because it's really explaining from the patient's perspective how hard it is, but how important it is for her to take the responsibility too and become an empowered self-advocate who says, oh, wait a minute. So it's not all my doctor's fault, and I'm not a victim of modern medicine. I've got to learn how to rewire my neurons into a place of believing that even though trauma's occurred, I am safe now.
Yes. Patients understanding that pain is not going to kill them is a big factor, and understanding that the pain is manageable and can be controlled with all these modalities, like giving the patients agency of these choices and empowering them with knowledge on our part is huge. But the self-advocacy in the endometriosis chronic pain world, you have to have it. I love it when patients come to me and say, hey, what do you think about XYZ? I saw this on this support group. Like, they're reading, people are reading, they're knowing that endo treatment is not simply surgical.
Right.
It's becoming more commonplace. So that's great. A lot of hope building up on that.
And it's good for you to say, like, we may be surgeons, but we cannot cut out trauma.
Correct.
It's kind of like a wound that is going to scar, and the scar then becomes part of the body. And if I use the word like a disfiguring, but it just changes the appearance, then are you going to get upregulated about it every single day or move towards acceptance of the situation? And I think if you can accept what's going on with regard to chronic pain or infertility, the prognosis gets better because they're not having that upregulation to deal with as well.
Absolutely.
Or grief.
Yeah. And it takes a village. It takes a whole village of people who understand this disease to help patients really get better. Like, I've learned so much in my journey of being a humanistic surgeon in seeing through disease process and how it's affecting patients' wellness and their quality of life, to the point that There's another saying by a famous physician named William Osler. He's one of the founding fathers of modern medicine in the United States. He said, you can't become a true physician until you've filled a cemetery. I know this sounds very riveting, but it's not about, it actually revolved around life and death. My extrapolation to that is suffering. When you see people suffering and you constantly see the different ways you can help them, if you're able to be humble enough to realize that healing comes from your experiences as a physician, how you've adjusted your provision of care to become more patient-centered, holistic, that takes time. And every surgeon comes out of training with an ego that's so massive that it takes 5 years on average
just to kind of approach the humility piece,
so that they can start being empathy and listen. And when that happens, the healing that comes with medical care is just amazing.
Mm-hmm. I don't think it's an accident that you found your way from Illinois to here and to team up with Dr. Iris Karen Orbach and her new branding of wings.
Yeah.
Right. So over there, it's all holistic. It's multimodality.
Correct.
Yeah. So as we talk about this idea of expectations, what might you say to your patients when you're talking to them about the personal discovery aspect? Do you refer them to psychologists? Do they seem to agree with you, or do you find that most of the time they're thinking that this is a surgery issue?
Yeah, there's a lot of emphasis on what surgery can do for them, and they're walking in saying, I need surgery. Mm-hmm. And I don't disagree.
And they're on a timeline. Correct. And they've been ill for a long time, and they want that to stop. But then you and Iris coming at it from the multi-modality perspective, is probably being heard as, oh, but that's going to take so long. So how do you address that?
So that's probably the toughest part of what we do on the counseling part, because in patients' minds, if I have an excision, I'm going to be fine. I'm done. Mm-hmm. Life's going to be good. And that's not the case.
Well, the way that you were just explaining it, I think if I was a patient who came to you and was hearing, oh, that's why it's doing this, it doesn't even really matter how it started or how long it's going to take. I can feel like, well, there's hope.
Right. And so to convey what we can do for them with accuracy and truth, we spend 90 minutes in our consult to talk about like what's happening in your life, what's happening now, characterize the pain. And in that 90 minutes, a good 30 minutes are spent in counseling about expectations from us to them, expectations for themselves, how much they need to be involved in their care plan, and the self-discovery that happens on their side, which means that they have to uncouple their mental state from their disease process and really address it with the help of professionals to deconstruct these little components of self-worthlessness, self-trauma, their history and how that contributed to this picture, and really understand what does it mean when endo inflames you and causes that own trauma itself. Because we think endo is inflammatory. It's not simply inherited. There's some features there. It's not simply autoimmune. It's not yet classified as such. Features of autoimmune is very present. And the chronicity of it comes from the fact that there's inflammation happening, which increases their immune response, which in turn affects their whole body, mental health and organs alike.
Well, the immune system and the central nervous system are very intertwined.
They're so intertwined. I'm reading a book now by a professor from UCLA, Dr. Mayer. Recommend everyone to read this book. It's about the mind-body-immune-gut connection. Mm-hmm. Very interesting.
What's the title?
The mind-gut-immune connection.
Okay.
He's published a book prior to that, which is very similar, but this is like an extension of it, which incorporates the immune body, the immune system as well. And to make the long story short, if you think of your core as being central abdomen pelvis, technically, your immune system is present in your bowels everywhere. Number-wise, 70% of your circulating immune cells are in your gut. Mm-hmm. 70%. And their role is to be the ongoing keepers of sterile environment and safe lack of infection situation. So you've got tons of bacteria in your gut, viruses, foreign food material, processed food, allergens, irritants. And when you have inflammation caused by endo, your gut becomes leaky. It gets exposed. Your immune system gets exposed to what's in the gut food-wise / imbalanced bacterial colonies, and that induces a response. And so your immune system has to fight it back, and that makes it a vicious cycle of more inflammation, which leads to bloating, intestinal cramping, pain, nausea, vomiting, mental fog, low energy, fatigue. The list is so long, and it crosses over into trauma-induced stress in your mind, which increases steroids that are adrenaline, cortisol, stress hormones, which make this picture even more intense. And so you need to break the chain, that link of inflammation, and it doesn't happen simply with surgery. The mind-body, the mind-gut connection through the vagus nerve is real, and people who get anxious can have diarrhea. Mm-hmm. How does that happen? Mm-hmm. Like it's not rocket science. This is very established in science. It is common sense at this point, and you cannot expect to heal from endo if you simply just cut it out.
Well, and in the patient's defense, it's not that easy to just escape inflammation or stop having inflammatory foods because it's pervasive. It's everywhere.
Correct.
When I talked to Iris in her episode, I said, I bet if we grabbed 10 people from the street and could do a laparoscopy, we would find endo in 9 of those 10 people. But how much it's creating a symptomatic presentation is going to be dependent on how she's eating, how inflamed her relationship or home environment is, and how much exposure to toxins she's had. Yeah. And then her own sensitivity to being uncomfortable, right? Because like we're all saying, the minute that those dominoes start falling, then the upregulation starts getting loud, and it's a different rate and a different intensity for everybody. But I'm sure exposures to microplastics and processed foods and foods that have so much hormone in them, we all have, even men have some degree of endometriosis or some sort of inflammation in the gut that's then leaking out and maybe creating like a sheath of something. Mm-hmm. Like I think if I go back to my original surgery and that clear fascia, who knows what it was, but it was definitely a sheath of something. Yeah. And I had been raised watching my mom grapple with extreme menstrual pain, so it was already inserted in my mind that there's trouble through here, because that was 45 years ago that I would have been watching all of that with her, and we didn't have so much processed foods like we do now. So how do we manage the patient's angst or worry or their own expectations of how overwhelming it is, right? Because yes, there's the layer of I threw out all of my plastics, or I stopped eating processed foods, I'm only eating whole foods. I get those patients. They're very anxious about being perfect.
Yeah. Aren't we all?
Yeah.
So there's no cookie cutter endo presentation. Every woman with endo has her own experience and her own profile of factors that contribute to the picture of how this is making them dysfunctional, whether it's pain,
Bread,
or
eating bread.
yeah, like every patient, like I don't have, like there's not a single patient that's the same identical presentation like the other when it comes to endo.
Mm-hmm.
So if you approach them the same way, you're going to get the same results on everyone, which is not what we do. Everyone gets a very dedicated, personalized approach. We assess their GYN history, their bladder function, bowel function, psyche,
Mm-hmm.
their diets, their sexual function, their musculoskeletal system. We do an extensive history and physical exam. We do mapping of pain on their exam, which is not just pelvic. The pain exam for patients with endo is not just pelvic.
Mm-hmm.
It has to involve the back muscles, the abdominal wall, and any extra pelvic source of pain. You need to look at it with a lot of suspicion because endo is not just pelvic.
Mm-hmm.
Extra pelvic endo is not rare.
Mm-hmm.
And this is also picking up in mainstream media. Once you understand that every patient is unique, you'll be able to help them. Because you have to incorporate all their history, all their trauma, social, societal, relationship trauma. For example, back to the patient you talked about earlier, a big component of their healing is having a partner who understands and is able to be open-minded about the pathway of healing. It's not unilateral effort.
Mm-hmm.
The best partner is the supportive partner in the pathway of endo healing. They need to go to the visits. They need to understand the science behind the mind-body, the science behind the immune gut, all of that. Once they hear it, they will be much more compassionate as partners, and they will be able to really advocate for their partners in this long journey of healing.
Mm-hmm.
It takes a year plus for patients to reclaim their quality of life, whatever that means. And it's not always perfect.
Mm-hmm.
But we want to transition from resolution of pain
Mm-hmm.
to regaining function
Mm-hmm.
as the main premise of what this whole hype about endo treatment is.
Right. And you just reminded me of something that is so prevalent on their mind. They may have a low ovarian reserve, not getting very many eggs on IVF.
Mm-hmm.
And only a few IVF doctors might say this could be related to endometriosis.
Yes.
And I can understand why they don't want to say, oh, it's likely endo that's inflaming your ovaries and
Tubes and uterus.
and causing a low egg output or diminishing your egg reserve, because the surgery healing time is substantial. But I've seen a lot of cases, they do the treatment and then they do their laparoscopy, and then they are healed enough by like 4 months out
Mm-hmm.
to be able to do in vitro.
Or even conceive naturally.
Right. we definitely want to bring that up, especially in the patients that are around age 40
Correct.
or over 40, where
Correct.
IVF science might be writing them off and telling them, no, they won't be able to if they take a pause and go take care of themselves through laparoscopy.
Yeah. I'm particularly a nerd and passionate about the fertility aspect of endo. So for me, obviously, we'll talk about this in more detail, but it's so important to have a reproductive fertility doctor who understands holistic care and the pathway to fertility. It's imperative. If you're trying to conceive and you're seeing a reproductive doc, they need to have these attributes, because only through that approach will they appropriately give you the best optimal chance to conceive. Most REIs stands for reproductive endocrinology and infertility. Most REIs are trained to do a very systematic workup, which is geared towards high productivity and high turnover, aka get the patients through, do the IVF, do the IUIs, do the fertility treatments, and get them pregnant and move on. If it fails once, we'll do it again and again and again. When you are with someone who understands that fertility is beyond the inability to conceive and that other features happen in it as well, simple question: do you have period pain? Do you have intestinal cramps? Do you bloat?
Pain with intercourse.
Pain with sex, painful bowel movements. Anything that suggests inflammation in the pelvis, it'll make them start thinking, well, maybe it's not simply a lack of a good egg and a good sperm. Maybe it's the environment where this is happening that is not conducive. So on the endo side of infertility, endometriosis is a known cause and confirmed to reduce egg quality, egg quantity, implantation rates, tubal transfer of egg and sperm. And on top of that, if you do conceive, you have poor obstetrical outcomes: preterm labor, premature birth, spontaneous miscarriages. These are not pre-fertility. These are lifelong risk. And on average, if you have endo, you're less likely to be fertile constitutionally, aka endo reduces fertility, even if it's mild. Mild, severe, the stages don't matter in this aspect. So it's so important to have an REI who looks at you not just as someone who can't conceive, because you can't be a functional mom if you have endo.
Yeah.
And that's a big component of, I've had the pleasure to meet some awesome REIs in LA who think that way. And before they do their
who think
work,
that you can just, who think holistically?
yes, who think, I think this patient has endo. Can you assess her for me? And every single one I've received had endo. And so when you do the endo excision with all the multimodal treatments, fertility goes up from a baseline of 20% up to almost 50%.
It's another example of saying we can help you become more fertile over time. That the science of aging equals dismal dropping outcomes, that really is not true. With patient advocacy, patient empowerment, and addressing these problems of subfertility. I think that's who I see most of the time. It's subfertile scenario. I think when we're thinking about extremes, that's another form of upregulation, right? Like black or white, fertile or infertile, but there are all these gradations of subfertility, and endometriosis covers a lot of it through the inflammation and the lowered outcomes and what it does to the eggs. It definitely speeds up the aging of the eggs process.
Right. And so it's not a clear-cut boundary where like you get to 35 and you're suddenly not fertile or less. Age is a factor, but I think inflammation is so much more important.
Well, when the women are younger, this is how I've learned about endometriosis. The first half of the stage of endometriosis is very wildfire-like, inflammatory, and those adhesions are coming out and they're really wrecking the immune system and nervous system. And then later in life, I guess maybe 40 and above, then it's more scar tissue. I don't know with the foods that our younger kids are eating now and drinking everything out of plastic cups and stuff. I don't know when the scar tissue phase 2 of endo, maybe that'll be showing up in their 30s, and early 30s. But is that kind of how it is? Like it's more about the inflammation in the beginning, and then it's the damage that's been done later in life. Because I have patients, they'll come in and they're 42 and they will tell me, but I don't have pain. I used to. And then I will say, well, in the early stages of endo, it is pain and inflammation. In the later stage, it's blocked structures and things covered with adhesions. So that is true.
It is to some extent. We see pain and inflammation with horrible and like adhesions you're talking about in very young women. And we see it in older ones too. It's almost kind of common practice to think that it's progressive and it starts with inflammation, which is pain, and then it evolves into more adhesion production. But it's not linear. It's not linear. So suffering from endo is not linear, and healing from it is not linear either.
Good point.
And people need to understand that, because if you are expecting to be suddenly this awesome person who's not in pain after surgery, and if someone promises you that, big red flag. Think about it, educate yourself. Nothing is linear with endo.
Yeah.
And that's why when I'm going to surgery, I'm always like big question mark in my head, like, what are we going to find? I can feel to a certain extent, but what will we see? It's a box of chocolates. It's not linear. Everyone's unique in their own trauma and their own inflammation and their own upregulation. And no one follows the same pathway of healing. It's all different.
Right. Well, and the reason I wanted to talk to you was because your compassionate approach, and a compassionate approach sort of implies that you have a reverence for the role of spirituality.
Yeah.
Right. So it's kind of like, what is that patient's spirit going to bring to the surgical table too?
Yeah.
Right. Meaning, how much energy is their body carrying for the healing process following the procedure?
Yeah. And do they have enough reserve? So that's a great notion, Danica. I have to say that when I'm looking at patients, when I'm assessing patients, I'm genuinely looking through dysfunction and looking at their reserve, their spirit reserve. So we're healing the soul beyond just the body. And how much reserve do they have there? I'm assessing it. I'm asking them, like, do you think you can do this? Can we help you do this? And most of them get the energy to do it. But if you don't assess the reserve on the soul side, the spirit side, you're attacking this blindly. Like I genuinely cannot heal someone who has sexual trauma surgically. I can't. I need a sex therapist. I need them to go deeper into those levels. I can ask, I can investigate, but if I don't ask, I won't know. And a lot of doctors don't ask about things like that. And so if you don't investigate the spirits and souls reserve, you're not going to be able to give them the best pathway. I don't recommend the same multimodal therapy to everyone. It depends on what they've done, what they have not done, what I think is going to help them the most.
Right.
And we become, to some extent, gynecologists.
That's a
on
great
top
term.
of surgical excisionists. And you need to be able to be humble about that.
Yeah. Yeah, it's true. That's a great term.
Gynecology.
Yeah.
Yeah.
Well, I teach the patients that the uterus is the second heart and the vagina is the second brain. So how they think and feel about their lives and their future, really, we know it, mind-body connection, neuroplasticity. People like Dr. Joe Dispenza is proving it with quantum healing and stuff. Where the thoughts go, the energy goes. And so if we have two patients and one of them believes that she's going to get better, she's more likely to get better than the one who thinks that there's no hope, no chance, and nothing makes any difference.
Yeah, and it's our job, me and you and others, to shed light on that possibility and empowering patients with, like, yes, you can do this. You can heal. You can beat this disease. It's not going to go away. It's not going to disappear. But you have the power and the tools to genuinely get your life back. It's not easy. It's not, but this is your lot in life, and how you think matters the most. Right.
It really does.
Well, I just wanted to mention that meditation, deep breathing, tapping, acupuncture, integrative diet changes, these are real ways for you and tools to get better. Like you can't get better in life with any type of inflammatory condition without doing these things.
Yeah, it's practice.
And all it takes is giving it some shot and having faith in the process.
Or educating yourself to understand the mechanisms so that you can have the intellectual knowing of why it's going to work.
Yeah.
Something like that. Because we get a lot of heady types and they don't really want to take it on faith, or they don't want it to get quote religious or something, but it's a spiritual practice. Mindfulness is maybe a more modern term for it, but like a practice at calming yourself down, self-regulating, going forward, especially as the world continues to get very loud and chaotic. And now we're aware that we're uncertain or our destiny. Yeah. Like that was always probably the case, but now we're hyper aware of it. Anyway, I don't want to go tangential.
No, you're not at all. I mean, one last closing statement there is, don't forget your vagus nerve. I want people to just understand that their vagal nerve is so important to keep it calm. And so meditation, deep breathing, tapping, sound baths, cognitive behavioral therapy, psychotherapy, all of this helps you address your thoughts and helps down-regulate this hypersensitive central nervous system through the vagus nerve. And so
is that important. Like deep breathing? Well, you just listed several different things.
Yeah.
I just got back from a 2-day trip to hot springs.
Yeah.
And so minerals to nourish tapped out adrenals so that they're not being on depletion, and then more like a raw nerve scenario. Going off the grid, right?
Yeah.
Putting emails in a different part of our mind so that they don't so they aren't perceived as threats and sources of stress, but like different kinds of lifestyle practices, and committing to a change and committing to having a better boundary with ourself and other people. In my book, the chapter about endometriosis is about having better boundaries with other people, which I think that's what it is, and a boundary with ourselves that consistently I'm going to remember to breathe, or I'm going to stay aware of my nervous system throughout the day. Like it can be a long day at work and you can keep your nervous system in a neutral state of regulation with the choice and just paying attention to it. A long day doesn't have to equal a super stressful day.
Right. As long as you understand and you're able to pick up on the physical signs. When you're angry, you get flushed, you feel heat, your heart rate goes up. Can you realize that? If you can, that's where change starts.
Right.
You start doing those deep breathing exercises, sleep hygiene, meditation. I mean, I do that myself, and it's never failed me. And it's made me a better human with the people around me. First of all, with myself, and second, with my kid, my wife, my inner circle, and my patients, and everyone around me. It's such an untapped resource that I think if everyone meditates, you won't have a single war in the world. It just takes some self-reflection.
First, we've got to convince people that it's worth the 5, 15, 20, 60 minutes, that the benefit and the outcome of it. So, and that's worth changing your schedule a little bit, or sitting still and just being okay with this noisy brain at first. Because it does just get quieter in there if you keep coming back to it and you keep staying committed to, I'm going to calm myself down. I guess, like if you go to surgery and it's excision surgery and you're still upregulated and it's been a year since, well, then if you're not employing some of these techniques, it's time to start. And healing is not always from without. It comes from within. And we're great at doing the external part of endocare, but the healing from within is something that patients have to really embark on. It's in their control, and they just have the tools and they have to practice it. I do think endo healing, a lot of it comes from within too. You can't expect the best results without excision, but you can expect the best results with excision and your self pathway of healing. Right. Yeah. Well, I really appreciate your wisdom today. I know the listeners do too, and that you took time from your busy schedule. How can my listeners find you? Well, I've joined Iris Orbach in her practice at Iris Wings. What's the website?
iriswings.com.
Okay.
Yeah.
And do you have an Instagram presence? Or not
The
right
clinic
now?
does. I've just started to get myself into the sphere.
Well, I wanted to say it's you having a boundary too with your energy, because when we're compassionate providers working with a group of upregulated patients, we have to take care of ourselves and space it out. But we also have to remember that there's enough time, we have enough energy, it's all going to be okay. And that is an example of self-regulating conversation in my brain, because it can be very overwhelming as the calm provider on the team when everybody's upregulated.
It's you learn how to adjust those energies, and it's not easy. It's not easy to provide great endo care. It's very demanding. I love it. I'm very passionate about it, and so is Iris, and anyone else who does it properly is. We're proud to say that we do it in a holistic East meets West fashion, because that's the only way that patients are going to realize their potential. So thanks for having me today, Danica. It's a pleasure.
That's saying a lot. Oh, it's my pleasure. Thank you so much. Thank you again.